Hi, you guys. Welcome to UWorld's Next Gen NCLEX review session. We're so glad you guys are here. Thank you for bearing with us while we get everything up and running. My name is Jackie, and I am a nurse here at UWorld. We're so glad to have you guys back with us today. We'll be coming to you guys 3 days this week as well. So we have a little agenda up for you guys, and today we're going to be covering maternal health topics and a little bit of newborn health as well. So we're going to be talking gestational diabetes, shoulder dystocia, and APGAR scoring. And we're going to do a question at the end of each section. So bear with us through all of this. To our friends on TikTok, make sure you guys share this session with everybody. The more the merrier. We want as many nursing students to join as possible. And as always, drop your comments in the chat. We have our content experts moderating the chat. They're here to answer any questions you might have. Let us know how we're doing as well. And I think we're going to just go ahead and jump in. I will say we have a little bit of extra content compared to normal today. So I would anticipate this is going to go over 30 minutes, probably closer to 40 minutes. So just a heads up on all of that. But we will make it as efficient and smooth as possible for you guys. But with that being said, let's go ahead and jump into our first major topic today. Again, we're going to be talking about pre-gestational and gestational diabetes. So with that being said, there's two types of diabetes that are kind of going to come into play with pregnancy. So first we have pre-gestational diabetes, which means the diabetes was already in existence before the client got pregnant. So think about existing type 1 or existing type 2 diabetes. Then on the flip side, we're going to have a gestational diabetes. So this is going to mean it's pregnancy induced. So the changes that happen in our body during pregnancy are going to cause impaired glucose control. So our pancreas is not going to be able to compensate and produce enough insulin. So the result of that is going to be gestational diabetes. Okay, so we have lots of great images and tables for you guys, but before I pull those up and before you guys get to see those and screenshot them, I want to ask you guys, make sure we're all engaged in the chat here. What do you guys think are some risk factors for gestational diabetes? So let us know in the chat. We'll look at those answers and then we'll hop back in. All right. And hello, everyone. Thank you to our friends on TikTok that shared our video. And congratulations to May, who just passed your NCLEX. That's incredible. We love to see that. Awesome. And hello, everybody coming from all over the world. Okay, I'm down to the chat where you guys have your answers coming in. Okay, so I'm seeing obesity, family history, large baby. Good answers, you guys. This is coming in on YouTube and Facebook and Instagram. Good job. I'm seeing a lot of good ones. Awesome. You guys definitely have a lot of these risk factors. Very good. BMI I'm seeing. All right. Awesome. All right. Well, with that being said, you guys definitely have a lot of these down already. So I'm hoping that this is maybe your second pass through with some of these topics. But we're going to go ahead and pull up a little table for you today. This is kind of going to give you a good summary of what gestational diabetes entails. And again, it's not all encompassing, but something hopefully that can help you with your studying. But again, regardless of risk factors or not, some clients are just going to get gestational diabetes, but we are going to walk through what some of those risk factors look like. So we know there are several risk factors that contribute to this diagnosis. So common ones are going to be associated with these are all going to be associated with gestational diabetes. These are going to be obesity. So think about a BMI over 30. Think about excessive weight gain during pregnancy. So your provider is going to tell you an expected amount of weight you should gain based on your BMI. So anything over that can increase your risk for gestational diabetes. A family history of diabetes is going to be one. A previous large for gestational age newborn. So having larger than normal babies, and then polycystic ovary syndrome, or PCOS. Okay, so we hit on some of our risk factors. Let's talk about screening and what that looks like, screening and diagnosis for gestational diabetes. So beginning around 24 and 28 weeks, this is when our clients are going to be screened for gestational diabetes. And the reason why it's at this time, this is really when pregnancy-related hyperglycemia or elevated blood glucose levels are going to peak. So this is going to give us the best indicator of if we have gestational diabetes going on. Okay, so what does that screening look like? So again, somewhere around 24 to 28 weeks, the client is going to perform a 1-hour oral glucose challenge test. And this is going to be done in a clinic setting. So what's going to happen is the client's going to arrive to the clinic without fasting. So that means they're eating and drinking just as they normally would. This doesn't have to be done in the morning, you know, like some things with fasting would be. It can be done any time in the day. So the client's going to arrive, they're going to eat and drink as they normally would. Then they're going to ingest 50 grams of glucose solution quickly. So it's like a little water bottle of this really thick, sweet juice. And it's for anyone that's drank it before, some people like it, some people don't, but it's a pretty sweet, thick, sugary drink, which makes sense. So once the solution is consumed, the client is going to remain NPO, so nothing to eat or drink for 1 hour. And then when that hour has passed, a blood glucose level is going to be drawn. So one thing to note too about this blood glucose level, it's not going to be a finger stick. It's going to be like a venous puncture. So blood from the arm, the hand, but just not a finger poke, not a capillary blood glucose level. So normal results for this are going to be less than 140 milligrams per deciliter or 7.8 millimoles per liter. And again, this is going to be drawn at 1 hour, and this is going to tell us what our blood glucose level is after consuming that really sugary drink. Okay. So knowing this, let's say our client's result is greater than 140. When this happens, we have to either confirm or rule out a diagnosis of gestational diabetes. And the way we do this is with a 3-hour glucose tolerance test. So now this test is like a little bit different than the 1 hour, and we'll walk through what that looks like. So first, with this one, the client is going to be fasting. So that means nothing to eat or drink for at least 8 to 10 hours before the test. So a baseline blood glucose level is going to be drawn. So this is going to be our fasting blood glucose level. Because we've said this so many times, we have to know where we're starting to know where we're going, kind of a thing. So again, we're going to draw a baseline test. Then the client is going to drink 100 grams of glucose solution, and then they're going to have their blood drawn at 1 hour, 2 hours, and 3 hours. So same idea, nothing to eat or drink in between. If 2 or more of these results are over a specified threshold, then a diagnosis of gestational diabetes can be confirmed. So you guys don't need to know these levels. If you're tested on this in the NCLEX, or typically it really is up to your nursing school what they're going to provide you. But on the NCLEX, this reference range for these time intervals is going to be provided to you. But again, key takeaways to take away from this screening kind of section here. There's no fasting before the 1 hour glucose test, but there is fasting before the 3-hour test. And then 2 elevated readings during the 3-hour test is going to confirm gestational diabetes. Okay. So let's move on. We're going to talk about complications now, and this is kind of going to guide us through a lot of our kind of next discussion too. So I know you guys can see the chart up there probably, but I want you guys to put in the chat, what are some complications of gestational diabetes? So let us know, and it could even be something that maybe is new information to you, or whatever first comes to your mind when you think about gestational diabetes. I'm going to see what you guys think. Awesome. Very, very good. Good work. All right. Oh, a lot of great answers coming in. So I'm seeing macrosomia. I'm seeing prolonged labor, excess fluid, which is polyhydramnios, hypoglycemia in the newborn, preeclampsia. Good job. Big babies. Very true. Good job, you guys. Okay, a lot of great answers. Everyone's coming in. I'm seeing Instagram, YouTube, TikTok. Thank you guys so much. All right, great answers. This is awesome. Oh, and I saw there's a question here clarifying when fasting is required. Fasting is only required prior to the 3-hour glucose test. So if you fail the 1-hour test, then you do the 3-hour test, and before you start the 3-hour test, you need to be fasting for 8 to 10 hours. All right, okay. So let's kind of jump into some of our complications. So again, complications of pregestational and gestational diabetes, we're going to kind of walk through this as risks to the mom and risks to the baby. So again, pregestational diabetes is going to be diabetes that's in existence before pregnancy. Okay, so starting with the baby, these are some things that you're going to commonly see. So some of our more common complications. This is going to be fetal macrosomia, so otherwise known as larger than normal baby. So macrosomia is going to be a weight greater than 4,000 grams or 8 pounds 13 ounces. So macrosomia can lead to pretty significant complications during delivery, like shoulder dystocia, and we're going to talk about that kind of after we get through gestational diabetes. So shoulder dystocia can occur during delivery, and other complications in addition to that is going to be polyhydramnios or hydramnios. You wouldn't believe it, but I did practice saying this word like 5 times before we started, but it still comes out a little tricky. Okay, anyways, that means that there's too much amniotic fluid around the baby, and that itself can lead to complications of its own. So that can lead to premature rupture of membranes and premature birth. So that means delivering before 37 weeks. It can cause placental abruption, which means the placenta detaches from the uterus, and with that we worry about hemorrhage. And it can also cause umbilical cord prolapse, which means the cord passes through the birth canal when the client's water breaks. And this is bad because when the cord prolapses, the blood supply to the baby is going to get cut off, so the baby is not going to be getting perfused. And this itself is an emergency. Okay, so when the baby is born, the baby is at risk for newborn hypoglycemia. So remember, maternal hyperglycemia can lead to newborn hypoglycemia, so opposites. So this happens because the baby is used to getting glucose from the mom, and the amount that the baby can produce is usually not sufficient compared to what the environment inside the womb is producing. So essentially, their blood sugar is going to crash. And then there's also with gestational diabetes an increased risk for stillbirth. Okay, so let's talk about some complications for the mom. So we just covered complications for the baby. What are some complications for the mom? So the risk for these like really big, heavy-hitting pregnancy-related complications like preeclampsia are going to be increased. So a quick note about what preeclampsia is. It's going to be a new onset of hypertension after 28 weeks gestation plus proteinuria, which means protein in the urine. And then in addition to all of that, you're going to have signs of some end organ damage. Okay, so if left untreated with preeclampsia, we're worrying about a lot of these really big complications like seizures, kidney damage from protein in the urine, and clonus or hyperreflexia, so those hyperreflexive movements in our knees. Another note about complications, there's a handful of complications that are going to be specific to our clients with pre-existing diabetes or pre-gestational diabetes. So these are going to include like an increased risk for infection and possible ketoacidosis. And again, we know ketoacidosis can be very harmful to a non-pregnant client, but when we include pregnancy, there's a little bit more risk involved. So again, when we're in acidosis, our blood is overrun with CO2, which is an acidic component, and that can be really toxic to our brain and our organs. Okay, we're almost through gestational diabetes. Let's jump into nursing interventions. Before we do this too, a quick note about our clients with existing diabetes. So these clients are most likely going to be followed by a specialist like a reproductive endocrinologist, and they're really going to get into the nitty-gritty of like insulin requirements, blood glucose monitoring, all those things that really provide a specialized approach to their prenatal care. But what we can expect as a generalist nurse when we're caring for these clients is really just to teach them, again, about frequent monitoring of their blood glucose and just, healthy lifestyle modifications during pregnancy, things like that. But again, when we're talking through nursing interventions for gestational diabetes, we're going to keep it simple. Nursing interventions are really going to be about the same as what they would be for a non-pregnant client, since we're just focused on what a general nurse would do. So not a specialized reproductive endocrinology nurse. So in the sense of the big picture, what we're going to teach the client is about healthy lifestyle modifications that can promote, healthy diet and exercise, things like that. Not all clients are going to require insulin, so certain lifestyle modifications will really do the trick to kind of treat these clients during their pregnancy. But in addition, we're going to teach the client about how to monitor their blood glucose per the protocol that's prescribed by the healthcare provider. For our clients that require insulin, we can teach them how to administer it, how to draw it up, where to inject it. And then we're also, of course, going to teach our clients about signs and symptoms of hypoglycemia and how to manage that. So again, we know anytime we're giving insulin, we have a risk of hypoglycemia. So we want to teach them some of those big picture signs and symptoms for that. Okay. But what is different in a pregnant client too that we really need to take into account is the baby. So of course, obviously, but we want to teach these clients about, monitoring fetal activity. So making sure kick counts remain the same, that the baby's activity isn't decreasing. Or if they notice a decrease in fetal movement, they need to contact the healthcare provider right away. And then again, since these clients have an increased risk of infection, not only due to pregnancy, but with this added layer of diabetes, especially for like UTIs and like vaginal yeast infections, we need to teach them about signs and symptoms of these complications, and that they need to notify the healthcare provider if these are observed. Okay, we did it. We're a third of the way through. We covered our kind of like antepartum big major topic of gestational diabetes. We're going to bring up a question for you guys. I will read it and give you guys a chance to answer. And then we will move on to our second topic, which is going to be shoulder dystocia. All right, so I will read the question, give you all a chance to answer, and we'll go from there. All right, the nurse is reinforcing teaching with a client who is at 24 weeks gestation and is scheduled for a 1-hour glucose challenge test. Which of the following statements by the client would require follow-up? Option 1, I will need to fast for 4 hours before the test. Option 2, the test involves drinking a 50-gram glucose solution. Option 3, I should not eat anything for 1 hour after drinking the glucose solution. Option 4, a 3-hour glucose tolerance test is needed if the result of this test is elevated. All right, let's see. Ooh, a lot of great answers already. Good job, you guys. Good work. A lot coming in on YouTube. Good job, Lex on TikTok. Good job, you guys. Instagram, good work. A ton of right answers. I think this means you guys have been listening in. That's awesome. All right, good work. A ton coming in on TikTok and Instagram, YouTube, Facebook. I'm seeing a lot of really good answers. All right, well, you guys pretty much have it, so I'm going to go ahead and say our answers. So our correct option is option 1. So again, this question is asking us the statement that requires follow-up. So we're looking for what the client, the statement that is incorrect that's being said by the client. So again, you do not need to fast before a 1-hour glucose test, so that's why 1 is an incorrect statement, which makes it our correct option. Okay, awesome. Let's jump into topic number 2, which is shoulder dystocia. Okay, so we have an image that we're going to bring up here, and then when we get through that, we'll bring up a table. You guys feel free to screenshot that. Again, it's not anything that's fully encompassing, but we'll hopefully give you some good starter points as you're studying. All right, so let's talk about what happens with shoulder dystocia. So shoulder dystocia is, again, it's an emergency, meaning immediate action needs to be taken place, and if not, that result can really be pretty negative for the both the mom and the baby. So what happens in shoulder dystocia is the baby's head emerges, but the anterior shoulder remains wedged behind the maternal symphysis pubis bone, or like the pubic bone. So in simple terms, the baby's head is delivered through the birth canal, but the shoulders get stuck. Those shoulders aren't making their way out. So clinical features for this, it's going to be like what you're going to see. So again, what it's going to look like at the time of birth. So again, it's going to look like longer at the time of delivery, it's going to look like protracted labor. So what this means is simply it's just longer and slower labor than what's normal. So this is really going to key us in that the baby is not like in the optimal position for delivery, or it's too large to descend into the pelvis appropriately, which is really what's going to slow that fetal descent, or the way the baby is making its way down in the birth canal. So again, that slow fetal protracted labor, that's really going to mean the fetal station, or where the baby is positioned along the birth canal, it's not changing. So again, this is going to indicate that the baby is either too big for the pelvic anatomy, or that it's stuck. Okay, so the last thing too that you'll typically see with shoulder dystocia is a turtle sign, or essentially the head is retracting back towards the perineum. So turtle sign is really what it sounds like. The baby's head is emerging, but then it's going to retract back in like a turtle does into its shell. So again, this is going to indicate that the baby is not moving through the canal as expected, and it's likely stuck. Okay. Next, we're going to talk about risk factors, and then we'll bring up our table. But again, I want to ask you guys, what are some risk factors? What do you guys think is going to be a risk factor for shoulder dystocia? So use that chat. Let us know. We've talked a lot about the baby being too big. So what are some of those things that can cause big babies, or the name of what that is? So use that chat. Let's see what you guys think. All right, good work. Large baby, big baby, macrosomia. Good job, gestational diabetes. A lot of great answers, you guys. Good work. Awesome. A lot coming in on Facebook and YouTube. Good job, good job. Yes. Risk factors, pelvic size, very good. Good job, you guys. Okay. Awesome. Well, we're going to bring up a table for you guys now. So again, we have a little kind of snapshot of some of the big topics to know, big points to know about shoulder dystocia. Feel free to screenshot that if it's helpful. So for risk factors, let's talk about this. So some patients have no risk factors. Again, things can just happen during pregnancy and delivery. But there are, again, a number of risk factors associated with shoulder dystocia. So again, these are mostly going to be aligned with the size of the baby. So this is going to, again, be like fetal macrosomia, or larger than normal fetal size. So again, 8 pounds, 13 ounces, or over 4,000 grams. Gestational diabetes, we talked about this already. We know this can contribute to a larger than normal baby. Post-term pregnancy is another one. So anything at 42 weeks or past. Again, babies grow so quickly in that third trimester, and they're growing faster and faster as they get to delivery date. And then maternal obesity and excessive pregnancy weight gain are other risk factors too. So again, those can all contribute to fetal macrosomia. All right, let's talk about nursing interventions. So what do we do when if shoulder dystocia is happening? So again, shoulder dystocia is an obstetrical emergency, so we need to take action immediately, and we need to know what our action needs to be. So our primary goal with shoulder dystocia is to facilitate a rapid vaginal birth. So what we need to first do is call for assistance. We're going to need help. We're going to need another nurse with us. And then we're going to lower the head of the bed, and then we're going to go into what is called the McRoberts maneuver. So we have an image of this for you guys to take a look at as well. So what we're going to do, we're going to assist in the maneuver also, such as the McRoberts maneuver, and this is going to involve 2 providers, like nurses. So these nurses are going to each have a leg, and they're going to sharply flex the thigh back against the abdomen. So again, those legs are going to be pulled back really far. So at the same time, one of the nurses is going to apply suprapubic pressure just above the pubic bone, and it's going to be applied to the fetal anterior shoulder. So the flexing of the legs is going to rotate the pubic bone and allow that shoulder to get unstuck. And then the suprapubic pressure applied to the fetal anterior shoulder is going to help rotate the shoulder free from the pubic bone. So these moves together are going to help get the shoulders unstuck, and it's going to give everyone our best chance at a favorable outcome for a vaginal delivery. Okay, we'll pull our table back up for you guys. Another maneuver that you might see is called the Gaskin maneuver, which involves having the mom move into like a hands and knees position. And again, this repositioning can help dislodge the shoulder from the pelvic bone. Other important actions are going to be to document everything that's going on, just as you would in any other emergency. And you're also going to want to call out time reminders. So things like 2 minutes have passed, because this is really going to inform the provider what interventions they need to follow, and they're going to instruct you as a nurse what actions you need to perform. So those are some of the things we can do as a nurse. And then let's talk about complications. So we're kind of moving our way through shoulder dystocia, but as you can tell from just kind of picturing this, seeing some of these pictures that we have and understanding more about what's happening with shoulder dystocia, there's some pretty significant complications or repercussions for the mom and the baby. So for the mom, they can experience postpartum hemorrhage or perineal laceration. So this can be, again, hemorrhage can be caused from a number of reasons like uterine rupture, but the lacerations, we'll talk a little bit more about what those look like. So these can range from like a 1st-degree tear, which is going to involve the vaginal mucosa and the perineal skin, all the way to the 4th degree, which is going to include tearing through vaginal mucosa all the way through rectal mucosa. So this includes like internal and external anal sphincters as well. So complications to the baby are going to look like neuromuscular ones. So it can be shoulder and arm like nerve injuries. So right here, kind of where our neck connects to our shoulder, we have our brachial plexus. So as you can imagine, if that's kind of getting stuck, you can have a little bit of nerve damage there to that bundle of nerves. The baby can also experience a fractured clavicle or a humerus, and this is sometimes an intervention that's required to actually get the baby delivered. And I know this sounds extremely terrible, but baby or newborn fractures, they heal very well. They heal very quickly and a lot of times have no long-term implications. Other kind of neuro-focused complications to the baby can be things like hypoxic brain injury or cerebral palsy. And unfortunately, shoulder dystocia can also result in fatal outcomes to the newborn from asphyxia or lack of air. All right, we made it through our second topic. That was kind of our big topic focused on delivery. So we'll pull up a question and then we'll move on to our last topic, which will be APGAR scoring. Okay, so we'll pull up question number 2, and I will read it, and you guys can have a chance to answer, and then we will carry on. All right. A nurse is assisting during the vaginal delivery of a newborn with shoulder dystocia. Which of the following actions should the nurse take? Select all that apply. Option 1, prepare for a forceps-assisted birth. Option 2, document the time the fetal head was born. Option 3, request assistance from additional staff members. Option 4, assist maternal client to push by applying fundal pressure during each contraction. And then option 5, flex the maternal client's legs back against the abdomen and apply downward pressure above the symphysis pubis. All right, let's see what y'all think. Good job. All right, good job, Victoria and Brittany. Good work, you guys. A lot of great answers. Again, this is a select all that applies, so you're going to have more than one right answer. I always say, and I know you've probably heard this before, but just take them kind of one option at a time and take a true-false approach to them. Think about things that are going to be expected versus complications, anticipated, not anticipated or contraindicated. All right, good work, everybody. Good job on Instagram. Great job on YouTube and TikTok. And good work on Facebook, too. Good job, you guys. Awesome. All right, well, with that, seeing all these right answers, I'm going to go ahead and give you the right answers. All right, so our correct options are going to be options 2, 3, and 5. So again, we talked about this as part of our nursing interventions. So we need to document when everything that's going on. This would include when the fetal head is born. We need assistance. Again, we can't pull 2 legs back at the same time. We're going to need another nurse to help us with that McRoberts maneuver, which is what's described in option 5. So again, we're going to pull those legs so the thighs are touching the abdomen. This is going to rotate the pelvis and allow the baby to get unstuck from the pelvic bone. And then again, a forceps assisted birth isn't going to be a solution for this situation, and we don't need to be applying that fundal pressure. We need to be doing the legs in conjunction with the suprapubic pressure. All right, good work. We're on to our last topic. So we did kind of antepartum delivery. Now we're going to talk about newborn care, and we're mostly going to just focus on the APGAR scoring. Okay, and we're also going to focus on just newborn care for like a baby delivered at 37 weeks. So nothing kind of in that premature range. Okay, so first things first, after the baby is delivered, either by vaginal delivery or C-section, we're going to do just a few basic interventions. So these are going to happen really fast, like pretty much simultaneously. You're not going to do like one, move on to the other, onto the other. You're going to it's all going to happen really fast all at once. So what we want you guys to remember is PSDS, which is position, suction, dry, and stimulate. So we're going to focus on position. So we want to place the newborn on the mom for skin to skin. Again, that skin to skin, it's going to help with bonding, breastfeeding, and really importantly too, regulating the body's temperature. Because remember, the baby just went from being in a really warm, cozy environment in the womb to this major drop in temperature kind of outside the body. So we want to make sure that we're regulating that big change of temperature they're experiencing. All right, so that's position. Next is suction. We want to use a bulb suction, and we want to suction out the side of their mouth and their nose. We want to get all that amniotic fluid out of kind of those important airways area so that they can breathe and get their lungs expanded. We also want to dry the baby. This is going to help prevent cold stress. Again, this is the same principle as drying off after getting out of a pool or out of the shower. Heat evaporates through the fluid, so drying the baby off helps with temperature control. And last, we want to stimulate the baby. And while you're drying the baby, this is kind of going to be when you're stimulating the baby. Again, you're going to be kind of, vigorously rubbing them and, making sure all their reflexes are intact. And essentially, this is going to help encourage crying and all the things we want to see to make sure the lungs are working correctly. We want a really fussy baby at delivery. That means air is moving and things are working. All of our, kind of neurosenses are getting activated. So simultaneously, while we're doing our PSDS, we're going to be assessing for the baby's APGAR score. So again, before we pull up our APGAR table, I want to ask you guys, if you know this, what is a good score for an APGAR test? Again, use our chat. I'm going to give you a hint. It's a number between 1 and 10. So what is a number that means we have a good APGAR score? Let's see what you got. Good work. Oh, good job, Mammy and Shelly. Good work. On YouTube, I'm seeing a lot of good answers come in. Awesome. Good job. Ooh, very good. All right. You guys definitely know 10's obviously a good score. That's as high as we can go, which is great. Good job. Okay. All right, I'm seeing a lot. So, all right, we'll pull up an APGAR table for you guys. Again, you can screenshot this if you need it for your nursing school or studying anything. But again, an APGAR table is a tool that allows us to rapidly evaluate a newborn's transition to extrauterine life, so life outside the womb. The score is based on 5 variables, which you can see on the table, and it's measured at 1 and 5 minutes after birth. So all these letters in APGAR, we'll walk through what they stand for. So again, we have appearance. A for appearance or color. P is for pulse. G is for grimace or reflex irritability. So that's when, the baby's face is all wrinkly and they're mad. A is activity and muscle tone, and R is respiratory effort. So again, we have this table for you guys to kind of follow along with as we walk through some of this. So again, each letter can score anywhere between 0 and 2 points for a max score of 10. So starting with the letter A, we're looking for a pink baby. Blue is going to indicate cyanosis or poor oxygenation. And this can either be observed by the skin or the mucosa. And so this is going to be our best indicator for how we score our A. Okay, P is pulse. So we are looking for a pulse greater than 100 beats per minute. So you can assess this using a stethoscope and you can listen and count. So, you can listen for 10 seconds, get your number, multiply that by 6, and you'll get what your rate would be for a minute. G, this is for grimace or reflex irritability. For this one, you're looking for like a cough, a sneeze, or a cry. Again, these reflexes are going to be typical in a neurologically intact newborn. Okay, A is for activity or muscle tone. So we want to be sure that our baby is not limp. We want to see some activity, some spontaneous movement, like their little arms and legs are going to be kicking. They're going to be fussy, but that's what we want. And then R is for respiratory effort. Again, we're looking for good breathing, like crying and chest expansion. And again, this is going to show that the baby's lungs are expanding and that air is flowing. Okay. So that's kind of what we're looking for in the table. Let's talk about results. Okay, so again, we're going to collect our APGAR results at 1 minute and 5 minutes. So if we get a score of 7 by 5 minutes, that means our baby is adjusting well to life outside the womb. So again, a score of 7 by 5 minutes is what we're looking for. That's what is really indicating a good transition to life outside the mom. So if by 5 minutes our score is less than 7, we're going to repeat our APGAR assessment every 5 minutes for up to 20 minutes. So again, if by 5 minutes we're still under 7, we're going to continue assessing them. Scores less than 7 are going to indicate that the baby is not adjusting well to life outside the mom, and they might need some supplemental interventions like oxygen support. So if we get a score between 4 and 6, this is going to mean that the baby is having some moderate difficulty adjusting. If at any time we get a score 3 or less, at any time, that means the baby is in distress and we need to perform some resuscitative interventions. And again, this is a more specialized intervention that'll be performed by a specialized nurse. And it's important to note, you don't ever want to delay resuscitation efforts or interventions just to collect an APGAR score. When you recognize the baby's in distress, you need to take action. And again, APGAR scores, they don't predict future neurological outcomes. It's just at that time, and again, a tool used to assess how the baby's transition to life outside the mom has gone. All right, we're in the home stretch, our last question, and then we're done for today. So we'll pull our third question up, and it's a little tight on that question, but I wanted you guys to have the APGAR table available to you so you can see it to help you answer this question. Okay, so I will read it and give you all a chance to do some calculations, and we'll go from there. All right, so the nurse is assessing a newborn at 1 minute of life. The nurse notes the newborn is completely blue, has a heart rate of 110 per minute, and is emitting a weak cry. The newborn has active movement of extremities and grimaces when the nares are suctioned. Which of the following APGAR scores should the nurse assign the client? All right, so I'll give you all a chance to answer. It's either a 4, 5, 6, or 8. All right, I'm going to see what y'all are thinking. Good job, Mammy. Good work. Good answers. Good job, Monica and Jenna. Good work, you guys. A lot of great answers coming in on YouTube. Thanks for participating in the chat. Good job, you guys. Awesome. Cool. All right. Well, I'm seeing a lot of 6s coming in, which is our right answer. So again, when we take all of these findings into account and we calculate that again against our APGAR table, we're going to get a score of 6. So option 3 is our correct answer, a score of 6. All right, you guys, that was it for today. The rest of the week, we have some exciting question drills we're going to do. So tomorrow and Thursday, we're going to go through maternal and newborn questions. We're going to just do 10 questions a session. We'll walk through them, give a quick explanation of the right answer, and just allow you guys to have some practice. We know here at UWorld, question practice is one of the most effective ways to get prepared for the NCLEX. The more you see these topics, the more learning you have, the more pathways you're creating in your brain for recalling this information. So we hope you guys will join us tomorrow and Thursday at noon Central Time. As always, these lives are available on demand on Facebook and YouTube. And most importantly, you guys are probably in crunch time for your NCLEX. We so encourage you to check out our 7-day free trial at nursing.uworld.com. See what we're all about. See our awesome questions and explanations, our incredible illustrations. We have lecture videos, note cards, our digital notebook as well to help you make outlines of any content you're looking for. Again, we encourage you to check it out. We know you won't regret it. And also check out our website as well. We have a lot of great information about the NCLEX test itself, what to expect on test day, how to prepare, how to make a study guide, all these important things that are so timely for you guys as you're graduating nursing school. So again, thank you for joining us, and we hope to see you tomorrow, same time, same place, and have a great day. Bye.